Buenos días a
Good
todos.
morning, everyone. Good afternoon, everyone. I am Dr. Patricia Anita Solis Sanchez from the Analysis Metrics and Evidence Unit of the Department of Intelligence and Evidence for Action in Healthcare. And I have the pleasure of welcoming you to this fifth seminar that is part of a series of seminars on COVID-19, the ODS goals of health and equity. This is about protecting regional achievements in neonatal health after COVID-19. It's important for you to keep in mind some uh, logistics details. This meeting has interpretation services to English, so you can find at the bottom right, you will find a globe. And to identify and select the language that works for you. We thank you for being able to share this session with us. And now I have the pleasure of handing the floor to Dr. Sebastián Garcia, the Director of the Department of Evidence and Intelligence for Action in Health. Dr. Garcia, the floor is yours. Thank you very much, Patricia. Thank you very much to all of you for being here. It's a pleasure to be able to be here with you today. It's a pleasure to greet you in the framework of this fifth online seminar on the series on COVID-19, the objectives for goals of the Sustainable Development Goals, which we have developed jointly with the Latin American Center of Perinatology and Women's Health CLAP under the title Protecting the Regional Achievements in Neonatal Health After COVID-19. I take advantage of this moment to greet my colleague, Dr. Susana Cerrullo, the director of the center, and thank her for all the collaborative work that we have been developing between the Department of Evidence and Intelligence in Health Protection and CLAP. Undoubtedly, in the countries of the Americas, there are important advances in the reduction of infant mortality as a result of many years of efforts in regards to establishing public policy focused on tending to the needs of our populations. But it's also clear that there are still challenges, important challenges in neonatal and fetal health that require a greater effort in the design and implementation of interventions. In many ways, the current pandemic, because of SARS-CoV-2, has manifested many of the great pending issues and gaps that exist. To be able to get to know in greater detail the challenges in the population's health and also in neonatal health, which is a topic that brings us here today, we need to have data and information that is timely, that has the necessary quality, and in the necessary formats, so that it can be constituted as useful information and thus have an influence in the decision making in healthcare, being that at national or subnational level, or even if we talk about regional levels. Specifically tending to those populations with greatest vulnerability, meaning it's not enough to have data and information. We need to have this in a disaggregate manner that allows us to visualize the problems that affect in a differentiated way to specific populations. This puts at the center of any effort, global, regional, national, or even subnational, to put attention and resources onto quality information generation that is useful for health management. This is what will allow us to measure the evolution of the indicators of neonatal and fetal health and related to the SDGs. And in that framework, the Latin American Center of Perinatology and Women's Health, the CLAP, and Department of Evidence and Healthcare dedicates its joint efforts towards strengthening interventions to improve neonatal health, and also in the use of information and its analysis to improve decision-making and the construction of public policy. So, the intense propagation of the pandemic of the coronavirus in 2019 in the Americas has exposed and amplified dramatically the presence of inequalities and inequities, which is a characteristic that was already prominent in the relationship of healthcare with the environment, social and economic environment, and even political environment in our region. The tests that are accumulated in the region point at recognizing a deep socioeconomic impact in the short and long term, with potentially serious consequences for the healthcare of the populations and for the equitable distribution of health opportunities and well-being at all ages. All of this has great implications precisely towards Objective 3 of the Agenda 2030 for Sustainable Development, which is based on the promise of not leaving anybody behind. This is the center of the session that we will have today, in which we will discuss aspects related to neonatal healthcare before and after the pandemic, precisely towards building paths that take us to the development of a post-pandemic context. In the first place, Paula Duran will talk about the challenges in neonatal health between pre and post-pandemic from the rights perspective. Then, followed by Dr. Oscar Mujica of the Department of Evidence and Intelligence for Health, who will develop the presentation called Reducing Inequalities in Neonatal Health, a formula to accumulate human capital. And finally, Dr. Nidia Cruz, child coordinator of the maternal fetal health, will share the experience in the kangaroo program in República Dominicana. I thank our panelists for their participation and for sharing with us this rich experience. Dr. Patricia Solis, I thank you for an amazing conduction in this meeting, and also everyone who has made possible this seminar, everyone who makes it possible that we can meet with the use of digital technologies and continue with a very important program that we have in the region. And of course, to all of you for adding to these efforts and being here with us this morning. Without further ado, I hand the floor back to Dr. Patricia Solis, and I thank all of you for your attention. Thank you. Thank you, Dr. Garcia. As you were mentioning, we will now go to the session with 3 presentations, and then after the presentations, we will have around 20 minutes for questions and comments, and we will then invite you to include your questions and comments using the resource in the bottom, which is the Q&A. And please include here any comments that you would like and the questions that arise when you're listening to the panelists. We thank all the colleagues that are greeting us from different countries and have taken the time to share this important seminar. We will hand the floor to Dr. Paula Duran, the first panelist. And it's important to mention that Dr. Paula Duran is a regional advisor in perinatal health of PAHO, based in the Latin American Center for Perinatology, Women's and Reproductive Health, CLAP, of the Department of Family Health Promotion and Course of Life. From 2010, Dr. Duran is Dr. PhD in Medicine Specialist in Public Health, Pediatrics, and Epidemiology, with over 30 years of experience internationally in research, in teaching, and also in formulating and evaluating interventions and programs. Thank you very much. Good day to everyone. It's a pleasure to share with you this seminar. I thank you for your participation. And of course, for my colleagues from PAHO, from the Department of Evidence and Information for Health Action, and Dr. Nidia Cruz from the Dominican Republic, it will be a pleasure to share these minutes that, as we're mentioning, I'm going to address the challenges in neonatal health and pre and post-pandemic from the perspective of rights. Health of newborns. So we keep emphasizing on the need to strengthen the work and increase actions in regards to visibility and the response to challenges that are stated And we will see in the presentation. And I would like to mark as an important challenge in the region of the Americas the approval of the strategy and regional action.
Que en el año 2008 y como un esfuerzo de distintas voluntades, de
different wills and alliances and interagency groups in the Ministry of Health, and the health of newborns was put in the agenda. So even though it's not recent, from that moment until today, a series of frameworks and action plans have been developed at global and regional level, taking in a way the experience that the region of the Americas had developed. And that is how the action plan of newborns' health and the world strategy for women's health, children and teens, that then addressed from an integral manner the health of newborns, but also some groups in the framework of the course of life where health has implications in the different stages of life until the action plan of women's health and children's and teens for the region of the Americas manifest what I was saying instance ago, and it's the visibility that progressively in the public and political agenda, the health of newborns has taken in the past years. And just to emphasize on the perspective and the vision that, for example, the Global Health Plan of Newborns states as a vision is the one where there's a world where there are no newborn deaths or stillbirths that are preventable, where pregnancies are desired and births are celebrated, and women and children survive, prosper, and achieve their full potential. Now, in the following minutes, I will talk about 5 central ideas in regards to which we want to analyze the challenges presented by the current situation. And as the first point, I would like to mark what the estimations developed by the interagency group of child mortality estimation for 2009 have developed in terms of the neonatal mortality rate and the stillbirth rate. And these numbers talk about 7 neonatal births per 1,000 live births, or 7.9 stillbirths every 1,000 births. And if we translate these risk values in absolute numbers, we're talking about practically over 200,000 neonatal deaths or fetal deaths that occur in the region of the Americas that have been estimated for year 2019. And that means also that approximately 1 perinatal or neonatal death is estimated per every 100 live births in the region of the Americas. This central data, I think, deserves 3 perspectives to be seen in its complexity. The first one is that we can see in the graph in the lower left part how between 1995 and 2017, there have been progressive reductions in neonatal mortality in the region of the Americas, although, and the second element to consider is the variability in the neonatal mortality rate between the countries in the region still shows great variations. The third element, and I take advantage to thank Dr. Patricia Solis for facilitating this information in this graph, is that even when neonatal mortality has shown, as we just mentioned, sustained reductions, the mortality in the component post-neonatal and in the group from 1 to 4 years has shown much more important reductions. And this, as a consequence, leads to the fact that the participation, the percentage contribution of neonatal mortality into the mortality the first year of life is progressively greater. In year 1990, over 50% of the deaths in the first year of life happened in the first 28 days. In the year 2019, we can see how close to 60% of the deaths that occur in the first year of life are concentrated in the first 28 days. These three elements are fundamental to understand the mortality, the perinatal mortality load, but it's also important to consider them in the light of the objectives established in the regional and global frameworks. From the global perspective, we have defined by 2030 as a goal to reach neonatal mortality rates below 12 neonatal deaths per 1,000 live births, and fetal mortality rates below 12 by 1,000 live births. And we see this with as a regional rate of 7 per 1,000 live births. That would be within the perspective, but the great challenge that the next presentation will talk about in greater detail, but the greatest challenge for our region is to reach, and this is what the health agenda for the Americas for 2030 establishes in the action plan for the health of women, children, and teens, is to reach neonatal mortality rates below 9 per 1,000 live births, but not only nationally, but inside the groups of the greatest risk, meaning indigenous, Afro-descendant, Romanical, rural population, etc. This is now the main challenge. But as I was saying, the situation does not end the analysis of mortality and the load of mortality linked to perinatal results is just as overwhelming. This graph, that I would also like to thank Dr. Guillermo Macias, with whom we're working around the analysis of the morbidity rate of perinatal conditions in the region, shows us that based on estimations of the WHO of 2019, this indicator, which is the years of life adjusted per disability, where we have ordered from greatest to smallest the groups of causes that contribute. As you can see, it's 20 causes that basically represent 100% of the years of life adjusted per disability. These are years of life that were precocious mortality or disease or disability take away the population from the population the possibility of having a healthy life. Look at cardiovascular disease, neoplasias, mental health disorders, injuries, intentional or accidental, neurological disorders, respiratory diabetes, genitourinary or digestive. They contribute among the first places. But look at how between these first places, the neonatal conditions and the congenital defects are two groups of causes linked to perinatal health that contribute close to 10 million years of life adjusted per disability in the case of the neonatal conditions, and a little bit over 5 million years of life adjusted per disability linked to congenital defects. And if we disaggregate these two groups a bit more, as I was saying, over 10 million with some differences between sex represent the neonatal conditions affecting healthy life and contributing to years of life with disabilities, with illnesses, or with premature deaths. And what are these conditions? Complications of premature births, and neonatal asphyxia and trauma at birth, or sepsis and infections in neonatals.
Otras anomalías cromosómicas, el síndrome de Down o el paladar hendido y labio leporino contribuyen en 15 millones de años de vida. Y estos son condiciones que en una gran proporción son prevenibles o evitables. Entonces, esto nos lleva a la tercera idea, que es en qué medida la accesibilidad y la calidad en el cuidado están presentes. Y sobre todo, si bien esto, como veíamos, eran estimaciones al año 2019, previos a la pandemia, esta situación de afectación y disrupción severa en los servicios de salud conduce a que, como podemos ver, estos son resultados de 2 rondas de encuestas realizadas a referentes de los países en el marco de la pandemia, en 2020 y 2021, y podemos ver donde tanto la atención prenatal, la atención del recién nacido, las visitas postnatales, en ambos periodos,
postnatal care visits have shown disruptions in more than 50% of the country.
factible lograr los resultados esperados en este contexto y sobre
Such context,
accesibilidad
and the accessibility and the quality of care that had shown necessarily that needed to be reinforced. These taking us to a 4th idea out of the 5 that were placed before, and that is the concept of equity and equality. I had not referred to it as I had said earlier, but to think that the prenatal deaths and neonatal deaths, the issues that contribute to the loads of disabilities, we know premature complications, congenital defects do expose children to higher risks and the need for special care, which is making everybody not to require the same kind of care. And it is important to then identify that offering quality care does not mean to have the same or to provide the same care for all of them, but for those that have specialized care and that they do receive it, and that those that need contact with the healthcare system actually can access it, and that key interventions are available and accessible for everybody, and particularly for those that have the most need. Last year, we launched with a clinical practice guideline for newborn, premature, and severely ill babies from the global perspective of the WHO, the UNICEF, and we have carried out guidelines for this kind of babies and patients. And this publication from last week by a group of the WHO with the immediate implementation of the kangaroo care shows us the very important value for newborns between 1,000 and 1,800 grams that are kangaroo babies and that receive that care immediately have shown less mortality risk on 28 days of life. So with the evidence and an evidence that shows that not much cost can show the effects of reducing what we have spoken about, it also shows us the need for comprehensive care and the need for information, as Dr. Garcia Cezanne had said at the beginning, that can reflect what is the situation, not only in terms of mortality, not only in terms of morbidity, but also in terms of quality care. And quality care comes from the care standards that are particularly addressed to severely ill newborns. And this is care prevention from the healthcare systems and services, but also participation in the experience of that care from the very families and the caregivers, which at the same time implies the need to strengthen human resource due to empathy and multidisciplinary teams, the need to provide physical resources, technological resources according to the needs, and to then supply and provide healthcare facilities that can provide from the very individual to the very wide, the best results. And then last but not least, and actually as a baseline from everything we've just mentioned, we find the law perspective. Article 6 from the Children's Rights Convention that has recently, probably 1 or 2 years, been celebrating the 30 years, establishes that member states recognize the right children have to life and the need to ensure to the most their survival and development. So then these 5 ideas take me to setting these 3 key challenges that are not trying to be reducting, but trying to actually highlight what we are trying to promote from the organization and SEEP. And one of them is strengthen the analysis, the need of analysis to establish goals and the consequenting analysis then of the achievement of such goals, not only in terms of mortality, but in terms of morbidity as well. The need to implement audits, and then the analysis of prenatal deaths to evaluate healthcare systems, the need to establish surveillance mechanisms and systems of those mortalities that in many countries are being implemented at several levels that need to be strengthened. And that would be like the first challenge. The second challenge we refer to is the strengthening of quality care, and particularly priority care for those children that have the most risk condition, with intervention as kangaroo care, the opportunity of the careful care and kind care, all of these things that we know there are initiatives that help reduce the impact we mentioned at the beginning. And then lastly, the participation of the key actors and the strengthening of partnerships and alliances in the areas and the Americas, the Neonatal Alliance for the Latin American and Caribbean areas from the healthcare ministries, public society, private society. We've met with associations of premature baby parents that are sharing their experiences, or families that they had to care their premature babies. And it is also important then that they are part of this process of care. With that, then I want to thank your assistance, your kind attention, and then I close by reinforcing these 3 challenges: to strengthen the setting of evidence with the perspective of equality, the strengthening of quality care, and the active participation of all actors. Thank you very much.
Muchas gracias, Dr. Durán.
Thank you, Dr. Duran. Undoubtedly, the information you're sharing about the load, the magnitude, and the trend of what's happening with neonatal mortality as well as fetal and prenatal is very important, plus the challenges that you had said at the end of your session. We'll now have the second speech from Dr. Oscar Mujica. Mujica is an evidence from the Evidence and Intelligence Department for the PAHO here in Washington, D.C. since 1997. Dr. Mujica develops cooperation projects, technical cooperation projects in regional and settings, local, regional with member states, and also with partner institutions in the strengthening of institutional capabilities and professional competences for the actual practice of concepts, methods, and instruments of social epidemiology, applied epidemiology, measurement, analysis, monitoring of social inequalities in healthcare, social determinants of health, health load, and epidemiology of healthcare services. And we want to thank all of you who are participating, that are already including your comments and questions, which we will answer after the third speech. And thanks again. Go ahead, Doctor, without further ado. Thank you, Dr. Solis. Good afternoon for everybody, or good morning to all those of the colleagues that are now connected in this fifth webinar, which it is a pleasure and a privilege for me to be here with you in this series. I want to thank the organizing committee for having invited me to share this topic. And I want to say that I've changed a little, as you've noticed, the title of the presentation, which was originally to reduce inequalities in healthcare. And I think what we need to do is not only that, but to eliminate them. All inequalities in healthcare have to be eliminated. We have to repair injustice, and that's what we need to do. And also, I think that desire to eliminate those inequalities and all of that it's mandatory to be able to gather human capital in a post-pandemic scenario. And I think this scenario that's coming because we're not in a post-pandemic scenario just yet. It's a scenario of large opportunities to rethink everything from the way we practice epidemiology or public health to the priorities and the budget that we give to healthcare issues. It's given time, we will learn the lessons we need to learn from COVID, but something that is undoubtable is that despite its old life, inequalities and inequities in the Americas have been brutally uncovered in the pandemic scenario. And that is very important not to miss because sadly, oh, I'm sorry, I think my slides aren't working. Okay, there it goes. So sadly, as Dr. Jen, our director, has said, and that's first thing she said when she took on the office about 8 years ago, is that we can't continue being blinded to inequalities. And that's what I intend to talk about in these few minutes. But to be able to connect with all, we do share some key concepts, which I think are fundamental for what we're going to see because it affects our sense of justice. Healthcare equality is a state of complete absence of unfair inequalities in the opportunities for healthcare. Just think of how much that is making an emphasis. Healthcare understood as a condition of physical well-being, mental and social well-being of people and human collectiveness in a super-individual level. These unfair inequalities due to historical circumstances that are socially determined. So it's not just any inequality. The inequality in healthcare are such differences in healthcare that are quantifiable among two or more population groups that are socially determined. That is, socially determined. Inequities in healthcare are inequalities in healthcare that are judged as unfair. And to judge something as unfair, you'll need to carry out a subjective valuation that will identify such inequality as arbitrary, unnecessary, and avoidable. If you see a certain inequality you think is arbitrary, that is unnecessary, then that becomes an inequity. And then is the same moral mandatory that needs to eliminate what causes it. Then we understand that inequity in healthcare it's awful, and we understand that the equity in health is a virtuous quality that intends focal protagonism and fundamental items for our common living, the social decision making, the criteria of equity that it's necessary, it's implied and is explicit, but it's necessary. And you can see that difference now during COVID. Yesterday in my country, we have seen the number 180,000 of death patients because of it, and in contrast of 69,000 that were known earlier, 3 times more. So this is something we're learning every day. Now, the identity of the peoples and their institutions are affected in the promotion of population health care. Then we also understand that healthcare equity is not just one, but the guiding principle of healthcare. Equity in healthcare becomes the key baseline, the pillar, the rational foundation for public healthcare as a social practice, which is to meet completely the needs of the population and to ensure the means by which everybody can access healthcare and be healthy. So With that in mind, with such context, then see what's happening now. Neonatal mortality among countries of the Americas that are ordered because of a social variable that has to do with human capital, by the way, is the Index of Sustainable Development, which is something that was constructed by PAHO, which is very similar to human development, that captures the three dimensions that it was politically defined in the summit of Rio, and sustainable development, the economic, social, and environmental dimensions. In fact, there isn't a sustainable development without those three dimensions that are covered among countries and only among countries. So look, in between the 2000 and 2004, those 5 years, you can see the 5 quintiles of the countries in the Americas according to sustainable development, starting with the fact that it has the less sustainable development, those that are the most vulnerable, to the highest quintile. And something that you can see here, and that Michael Marmol took like 35 years to put together, which is the healthcare gradient. And as the social position improves in the countries, then neonatal mortality is reduced. And the following 5 years, we find the same story. Between 2010 2014, we find the same story. And then in the last 5 years, in the pre-pandemic time, we find the same. There are certainly some important changes, of course. One can see that in all the 4 packs of 5 years for each of the quintiles, there's always been a reduction. And in fact, if we notice, the reduction has been greater in the quintile of countries with the most social advantage. The reduction, the leap has been of 2 less neonatal deaths for in every 4 or 5 years, going from 21 to 19 to 17 to 14. So it's 2 less by each every 5 years in the highest position, while in the most advantaged group, the reduction is even smaller. And it's something that happened in all of them. But the bottom line of this, the elephant in the room, as the phrase goes, the obvious is that there is the deep inequality. There are gradients of inequality that are further determined, not conditioned, but determined by social inequality. And as you can see, our region, the Americas, is painfully the most unequal one, not only in income distribution, but it is also in the social opportunities. That is why COVID has hit the countries so badly. This information, which is among countries, is one we can see like this. This is a lot more sophisticated in an analytical standpoint, but is about the absolute inequalities. And what we can find here is put together all the countries according to their grading defined by sustainable development. The level of inclination of inequalities are going beyond the situation, 0 becoming the social position that is in the most disadvantaged, the poorest countries, the ones with the least education and least environmental development, toward 1, which are the countries that are doing better. And as we find in the first place, the grading that the most inclined is the worst. And what we find here is very positive news that according to time goes by, the 20 years that we've been doing for this millennium, the gradient has gone flattening. And that is always good. It means that the absolute inequality has been reduced, particularly because action in the most disadvantaged group, which is what it should happen, and that is very clear.
If we see relative inequality, how much have the poorest improved compared to the improvements in the richest? We see the curves of inequality concentration. So I was saying there's 4 curves, but we can only see 1 because relative inequality was not reduced. For the poorest 20% of the Americas in the past 20 years, almost 40% of neonatal load or burden is concentrated, when what would be equitable is that this 20% would only accumulate 20% and 50% only 50%, the equidistribution line. There we have not had any improvement, and this is very important because different than absolute inequality, which tends to fall when on average in the region mortality falls, relative inequality only diagonalizes or comes close to the diagonal when the speed of the reduction of neonatal mortality in the poorest groups is higher than the speed at which neonatal mortality is naturally reduced in the richest. But we cannot see a change that is so marked in relative inequality. Doesn't speak very well about our focalization efforts. We need to do more. We can still see this. It's the same data. We can see this in another way. This is the trend of inequality. And look at the graph is a little bit weird because it's a negative scale. It means that it's focused on the population at the greatest disadvantage, and the equity challenge is 0. The index of inequality of the slope, that is this metric that summarizes the magnitude of inequality in a single number, should be 0. We're very far from 0, as you can see this curve. However, we see that the region is getting close to 0. There's still a long way to go, but it's getting close. In these 20 years, it has gone from negative 21 to 11. 21 means 21 dead kids per 1,000 dead neonatals per 1,000 live births, in excess due to the difference in sustainable development between the least developed and the most developed countries, to 11 neonatal deaths per 1,000. So the absolute gradient has reduced to half because it takes all the information available. And this is with relative inequality that, as I say, it hasn't really changed. This is the uncertainty. It basically hasn't changed, meaning we have to concentrate our efforts in the territories, in the populations where this mortality is focusing. But this should not call to our attention, nor COVID should have opened our eyes in the most brutal way, because this is a sanitary and social legacy of the Millennium of Sustainable Development Goals from 20 to 2015 that had these 3 things that we had here. Maternal mortality. So we had to reduce the number from the 90s to 2015 in 3/4. We did not achieve this. It was in 100, it went down to 50, but it went down to half. It's not bad, but we didn't reach it. So childhood mortality, we needed to reduce 2/3 of the value that we had in 2015. Okay, we had 25, went down to 15. Good. With TB, the goal said we need to revert the incidence, the curve. Well, we were able to. We were in 56, we went down to 28. So everybody's very happy, right? The problem is that we are blind, and we have been blind to equity. And this is not surprising because the SDGs, even though they talk a lot about equity and indivisibility and not leaving anybody behind, all of its indicators are averages, and they are actually just global averages. If we see the concentration curves of inequality between countries for each one, in these 25 years from the 90s to 2015, inequality did not move. It did not move. And we have, for example, that over half of the TB burden incidence is concentrated in the 20% of the countries with lowest human development. So this is an old and horrible story that we have not wanted to look at. So what is the legacy? Regional success due to averages without appreciable improvements. Within the countries, these phenomena are also occurring. This is not between the countries, this is within the countries. Based on the DHS and mixed surveys that are available in many countries, you can see this is a very good paper published in the Pan American Journal of Public Health. And you can see these little points. These are equiplots or equigrams. And each little point is 1 quintile of the income. And here you see the colors to recognize which are the poorest and which are the richest. It's a relative social position for 2 moments in the time that have Bolivia. It has reduced. We're only moving this towards the left. So we're bringing this close to 0. Look at Brazil in 1996. Look at the inequality. All of the distribution moved to the left, but inequality and the range, the amplitude of the distribution did not move. Colombia moved to the left, meaning to 0. It went down in its national average and dramatically reduced inequality between the 5 quintiles. The same thing happens with the Dominican Republic, even though it didn't really change on average. What I want to say here, because you know this very well, is that there's a lot of inequality in our region. This is another graph that shows other countries based on survey data. In the horizontal axis, this comes from the Health Equity Assessment Toolkit from the WHO that is available, and you can analytically play with all the data of the surveys that is there, and you can see that the average of the country in neonatal mortality, for example, if you read here, Peru had more or less 10, Dominica had 25, Guyana had 22. This is a national average. And here in the vertical, an indicator of inequality within the country in neonatal mortality as per income distribution. So we have -8 in Peru, and it goes to +4 in Dominica. This is a referencing, and this tells us not only in terms of the regional average that there's differences, but also within the countries and the distribution of mortality in this case. There's also inequality, and we could also keep showing some very important data, neonatal mortality and social inequality and its determinants, and in the proximal ones, like for example, prenatal checkups and deliveries with qualified personnel and other determinants of care, there's deep inequality in the regions of the Americas as per income quintiles, but also per educational level. And as you can see on the right, there's severe inequality because of ethnic groups. It's a determinant of identity. I don't need to say who are worse off, but this is deep inequality. Now, how does this go together with the human capital concept? Let me share with you a few points on human capital. It's a fundamental issue, fundamental. COVID would not have hit us as it has if we had generated or built greater human capital in the regions of the Americas. And then you will see social capital. The economists understand human capital as a group of knowledge, skills, health, and values that contribute to the productivity of individuals. They consider human capital a determinant of economic growth, and usually it's characterized by the educational level of the workforce. This is from the economist's point of view. Social epidemiology sees it a little bit different. It considers that human capital is the inventory of knowledge, skills, and aptitudes, and other individual skills that make possible to manage in a healthy way adversity, like COVID, like being left without a job, like having to stay at home or having a sick patient, adversity, not having something to eat. Manage adversity in a healthy way. Related to this, but different, this is the concept of social capital. Originally, in sociology, and I thank Uriel Solar, who has made me think a lot about this. From the sociologic perspective, social capital is defined as the people and family skill to obtain resources thanks to the fact that they belong to networks and other social strategies. How important is this in COVID? And from the social epidemiology perspective, that is a little bit broader, once again, it's a public good. It's not something that is inside the individuals, it's collective. It's the reserve of shared social resources and contextual factors based on reciprocity norms that generate social cohesion, credibility, and reliability in the institutions, and general concern for others' well-being and solidarity. That's social capital. Take a look. This is the gradient of neonatal mortality as per social capital in the Americas in 2019, right before the pandemic. We can see these points are a little bit far, but this is with a weighted regression due to the size of the population and a log linear function to take this, that is called the effect of marginal utility. What we see here is very clear. There is a social capital average index that is built with 4 great criteria, including reliability in institutions, social reliability in others, the capacity to get together and be solidary. The highest, the closest to 1, better. What does this mean? Neonatal mortality comes down as social capital increases, and it's dramatic. This is at country level, but it can also happen, it can also be reproduced subnationally. Now, human capital is central in the 1,000 first days of life. And there's a series of great articles here. The first series of the Lancet in 2003 on child survival talks about this topic of human capital, including this great paper by Cesar Vitora on the equity focus. That was back in 2003, 3 years after the Millennial Development Goals start coming up. And then in 2008 and 2013, the Lancet issues 2 series on maternal and child nutrition, where it centrally documents human capital and the global strategy that will also be presented by Paulo of surviving, transforming, and prospering. And this is essentially the human capital concept that is behind this. And now, Lancet just announced, or in a few weeks, there will be 5 new papers of review on the importance of human capital in the first years of life, in general in the course of life, but in the first years of life, to create resilience and equity. It's central then to see that, and maybe this is bold, but more than reducing the average, the regional or national average in neonatal mortality, we accumulate more human capital if we reduce inequality within the country or in the region. There can be a trade-off, an elective transaction. We could sacrifice a little bit of the improvement in the national level while better distributing survival, which is the first step of this global strategy to generate human capital, and also so that our populations manage adversity in a more healthy way individually. And of course, we need to generate social capital that allows us to manage equity in a more healthy way. Finally, as we said in the second webinar in this series, Abajo is stating 3 concrete proposals, in this case from SDG 3.2.2, neonatal mortality. 1 is to formulate quantitative goals that are explicit in inequality reduction, explicit. Then monitor inequalities. More than monitor, it's creating institutional capacity to take a look at inequalities and generate accountability in our promise of doing things without leaving anybody behind. And third, that this evidence informs decisions that are the most important part, not only quantifying just to quantify or monitoring just to monitor, and informs the decision in public health with equity focus. At the end, what is stated is this: we need to see if we improve or worsen in regards to average, but simultaneously see how we improve distribution, reducing inequality or extending inequality. We can also have better neonatal health without leaving anybody behind if we improve the average and simultaneously reduce social inequality. Thank you. Okay, I'm 2 or 3 minutes late. Thank you, Dr. Mujica. Undoubtedly, the challenges that you are stating in the title of not reducing and not eliminating, instead eliminating is what we need to think about first, then act. Now we will have our third and last presentation. Once again, we invite the participants to include their questions. We already have several that are being included in the chat and also specifically in the Q&A. We invite Dr. Nidia Cruz Otañez. She's a pediatrician and neonatologist. She is part of the team in charge of drafting national regulations and protocols in the Ministry of Health in the Dominican Republic. She is the national coordinator of the strategy of attention integrated to child prevalent illnesses, IEPI, and she is a coordinator of the maternal child and teens health in the ministry of that country. Thank you very much. Good day or good afternoon to everyone, depending on where you are. It's a pleasure for me to be here this morning and be able to present before all of you. And I want to thank for the opportunity for the invitation. And we will be presenting this topic. And as the panelists before me mentioned, we are talking about inequality in neonatal mortality. In this case, we are going to talk about a strategy, a program that we have been implementing for a few years in the Dominican Republic. And we will be sharing with you the experience of the kangaroo program in the Dominican Republic. So in these 15 minutes, we will try to summarize this. Just as a reminder, we know that the kangaroo method is a technique for premature babies and low birth weight babies that will be involving these 3 components. Everything with the objective of improving the survival of our newborns. And this is skin to skin to guarantee the temperature and the thermal control that our premature babies need when they're born. Also, it strengthens exclusive breastfeeding and will strengthen follow-up and support to this triad that we all know has a lot of benefits, both for neonatal health, that is mother, newborn, and involves the family, the complete family. Emphasizing on the context of prematurity, regardless of the fact that we have been talking about this before, it's worth mentioning that mortality due to prematurity is still causing problems for public health in the developing countries, because we know all the complications of being born prematurely because immaturity of the organs and neurological damage, eye damage, and the WHO estimates that 15 million kids are born prematurely each year. So it's still a problem because it's the main cause of death in children below 5 years. But what happens then? 3/4 of these premature babies could have access of quality care, and especially using efficient care like the kangaroo method, because it will help reducing morbidity and mortality in neonates. In our country, the Dominican Republic, 8 of every 100 newborns are born prematurely, meaning that we need to keep implementing programs like this one that can help us to improve survival of our newborns. Currently, mortality in our country has been reducing in a few years thanks to these interventions that we have been able to do. We're talking for 2013, we had a mortality of 21 per 1,000 live deaths, talking about neonatal mortality. However, we now see a comparison in these 3 years from 2018 to 2020, where we have been experimenting a gradual reduction in regards to our mortality in newborns, specifically in the first 28 days of life. And this is because of the effort and dedication and interventions that have been implementing. So going into the kangaroo program of the Dominican Republic, it comes up in 2009 when one of the regional doctors, hospital San Vicente de Paul, were trained by the USAID project in the kangaroo method. In year 2010 and 2011, they were certified as a center of excellence, and they got the training in the kangaroo program, and at the same time it was implemented in different hospitals. By 2014, another of our maternity wards, San Lorenzo de los Mina, was able to be certified as a center of excellence and also certified to train other health centers in the program.
All of this has come to improve our interventions in neonatal healthcare. And by 2018, these two centers that had been certified kept on replicating all training for human resource and for the staff that would be working with the different kangaroo programs. And up to the date, we have other centers that are implementing such method, that is 4 centers. Which has shown a lot of benefit. And we had the benefit and the opportunity back in 2019 to receive through USAID an assessment done to the status of the kangaroo program implementation in the Dominican Republic, which enabled us to be able to determine findings and the considerations that could be considered so that this method could extend and could be sustainable in time. This enabled us to improve a lot of the issues that we had been implementing, and at the same time to strengthen our services nationwide. Currently, in the country, we have been developing these 3 modalities of the kangaroo method. It isn't implemented in every center because some of them had modality and others don't, but we keep on moving in the process so that all centers can have these 3 modalities and that each one is showing a specific benefit for this population. So we count on the intra-hospital modality, which enables our moms and relatives to start with the method from the neonatal unit, even with our newborns that are hospitalized, which enables the mother to keep on learning and strengthening that bond with her child and how is she going to manage it. But once children can receive the discharge from these units, we have then the scenario that some may have not gained the suitable weight, and we also have moms that live in far locations, in making it more difficult to have access to a kangaroo program in the medical community. So we've decided to implement the kangaroo lodging, allowing moms to have a room where she can stay while doing the kangaroo method with her child until she's able to adapt and the child has gained the suitable weight and needed conditions for the discharge toward the third modality, which is the ambulatory method, which is something that we do through previous appointments. And in that way, we are able to continue to follow up to our children. These are three modalities that we've been implementing in some centers that I'll show you about. Here's a list and this chart of some of the hospital centers that we have in our country that are currently providing this program. And we can see in terms of care modality, most of them have these three modalities, as we've seen, the intra-hospital, the kangaroo lodging, and ambulatory kangaroo care. And with the ambulatory part, we are working to improve this condition. These are the other hospitals that we have for a total of 11 healthcare centers in the different provinces that provide the service to the population. And we've also been implementing the early stimulation. We already know what is all the neurological damage that all these children can endure. So this will provide a lot of benefit in terms of those thin and thick matricities with the trained staff. And for our babies to receive the benefit and to achieve at a certain given time all these skills of development that they require. Here's an image of how we've organized these early stimulation areas. Sadly, not all centers that we have can provide such comprehensive care room, but most of them are already having it. It's already identified. The service already being provided, and we've achieved these kangaroo program services at a nationwide level with the purpose to keep on replicating it. And so I wanted to bring this example to you because it strengthens this link and this bond mother, child, relatives. We've been trying to integrate the fathers and the caregivers in this role. And as you can see, even during pandemics, we have been working. Because as you can see, we're using the face mask and accessing the services despite certain difficulties. But we've tried to extend the service and to provide care to our newborns. Just, we know that one lost moment is a bad consequence for them in the future. Last year, also in 2020, in July 2020, we were able to launch this national legislation when we carry out an assessment in 2019 with the USAID when we were on the process. And the thing is that we didn't have at hand that legislation from the public health ministry that would enable us to provide the suitable care for kangaroo services. So now, thank God, and despite every difficulties that we might have faced, we were able to launch and publish this, which is in the website of the Public Healthcare Ministry of the Dominican Republic, which is through which the people access to our services, and so they can have the timely information and access to this service that is really improving the healthcare for our children. So then what happened then when all countries were hit by COVID-19? And such services that are as important as this one were also affected. And so despite us having to implement certain strategies and modalities of care to not close this service completely so that our children can keep on receiving care. We all know that there was a limitation of human resources at every healthcare center, which of course brought an impact to the kangaroo program. And in the Dominican Republic, we had to select some maternity cares that had the program because they were used for COVID patients. So then this program for those children had to use other care modalities outside what it's normally done to be able to provide follow-up to our babies. And one of those were to phone follow-up for premature babies or low-weight babies that needed that direct care to implement some methods for the authorizations of procedures, analyses through online consultation, some on-site consultation, and to provide ear and eye care as well, which is part of the program. One of the centers where we had quite a few newborns that had been born during the pandemics and that were part of the program, we had to coordinate in a particular way. And I can share the experience that at a certain we had 23 newborns in this modality, and we had not been able to do the eye doctor visit. And so there were 3 children that showed damage at a retinal level, and we happily were able to have a timely diagnosis, and they received their surgery. Also, 2 children with hearing issues that are now have their ear sets. And these are very beautiful experiences that show us that services can't close. They have to continue because these consequences can be for life if we don't manage them timely. Now, our kangaroo programs have had or have a lot of strengths, among which we can highlight, and to me, I believe is the most important one is that staff working in the kangaroo program, because they're motivated and they're excited to do this implementation in their healthcare centers. When parents are not around and they need to receive that kangaroo care, we can see our physicians involved in this care for children, because it is actually something that shows us how motivated they are. It's what's made us and encouraged us to implement this in several hospitals in our country. And also, our centers now have the eye doctor care for these children within the program, to those healthcare centers that have neonatology care residents. We have implemented the requirement for these residents to circulate around this program so that once they're graduated, they can implement and keep on replicating to the places where they'll be moving. And as I said, we have a protocol of national care for all kangaroo programs in each of our healthcare centers that keep adhering to the program. But although all the efforts and everything we've already done, we still have a few challenges that we will keep improving in time, such as the lack of trained staff to provide this care, which includes a team such as nurses, some neonatologists, psychologists that we still need. Um, Sometimes we lack some administrative coordinations and social work to be able to provide better care. Also, we need to improve the mechanisms of national supervision and hospital care. Oftentimes, the staff that is trained in the program is transferred elsewhere, and so to implement again with others as well. So we have to keep on growing to have a better geographical coverage that can be more suitable, because not all regions in our country have this service to be able to help moms from different provinces to move to a close place to their communities where we can have the service, and that particularly the ambulatory kangaroo service can have follow-up, can provide follow-up to their newborn without them having to move to an even farther hospital care center, because it would imply a lot of more resources. Here's an example of what we've mentioned and the distances they have to cover, to say that not all units in our country have an open unit that enable parents to provide 24 hours care, or the hours they have to be with their babies. Some of them even don't have sufficient time to come and offer care to the patient. Maybe they need a better space that can keep on encouraging breastfeeding and to encourage this personal care that our newborns need. Probably in some centers there's not sufficient provision of milk extraction devices, that we can keep on implementing milk banks for some of our maternity care to be able to encourage and favor breastfeeding in our children. And sometimes some girls are not provided. So despite all that, we've done a lot. We keep on doing a lot, and we'll keep on replicating and training stuff so that most our centers or main maternities in the country can keep on implementing the kangaroo program, which is really beneficial for this population because our figures are still quite high regarding the birth of premature babies, but we keep improving. And today, we have had discharge of many of these children from these programs with a survival rate of more than 95% for those that belong to the program. So this is part of these cost-effective strategies with minimal costs that are really working.
Hablaba Pablo. Muchísimas gracias por su atención.
So thank you very much for your attention, and I expect it's been useful for our kangaroo program. Thank you, Doctor. It's certainly been very interesting to see all the work that you've performed, and there were we had some questions in chat that were asking about this strategy that is known and that is very important, and it's being implemented in many countries. And an apology for the lack of time, which is always our worst enemy, and we have a short Q&A session with some of yours. I'll read the questions and then pick which of the speakers would help us. Some of them have been specific on that. The first one is for Dr. Pablo Duran from Bolivia. We have the question that says, for purposes of comparison among countries, what are the implications of managing rate or reason of prenatal mortality or fetal mortality? Thanks a lot. Well, first of all, that's something we always promote for the use in the country, which is the most ideal thing to have information, reported data, which implies a whole work of consistency and quality and all of that. Now, the international comparison, which is one we always promote and carry out from the use of estimates, because it actually enables us to use a uniform criteria. Then I'll say that every approach, either by reported data or estimation, will have pros and cons, but to respond, I say that for the international comparison, both fetal, prenatal, or neonatal estimates are what we have today to assess this. Dr. Mejica, I would like for you to share your point on this. Breakthroughs in reduction of neonatal deaths could be considered unequal because of the record of prenatal and neonatal deaths of some countries in the region. Thanks a lot, Patricia. Thanks for your question. I'd say that Patricia is even better qualified to comment on this, because I think it's a very important question, and a short answer will be yes. I believe the issue of the sub-recording of mortality and the terms of efficiencies and the quality of the record, determination of cause, and etc., are the best determinant of what we have in neonatal mortality. Plus, we know quality issues and complexity of record taking of the overall mortality is linked to other determinants of healthcare inequalities, which may be higher in the less income countries, or with less in countries that have a better social condition or better coverage of sanitation and water. So it is a determinant. But to solve the issue of the sub-recording of mortality does not solve the issue of inequalities. It may actually just make them more extreme, if anything. So it's certainly something very important. It was mentioned by Dr. Sebastian Garcia during his introduction. And we don't want to just measure because it is necessary to monitor inequalities in healthcare. One of the issues to actually report correctly, the key important aspects for investment and to keep on moving to such proposal is to actually invest in the quality of information systems, data, records, and of course, in human talent, where we need to keep on strengthening and polishing our analytic competences to monitor inequalities. Thank you very much, Patricia. Sure, absolutely. It is a complementary approach on quality of information. It's something that we always promote as a strategy to evaluate what's happening, particularly in the fetal as neonatal components, not only in terms of figures, but also all the variables and, of course, the cause of death. Now, on this question, I would like for Dr. Pablo Duran to answer it with his experience. What will be the impact that it has or will have for mothers and newborns, the restriction to contact between both and the relatives because of the pandemics and what pandemics have brought? Thanks a lot. Excellent question. And it's also hard to answer. We do know for a fact that the lack of contact established, particularly at the beginning of the pandemics, is not even advisable or sustainable by evidence, and it's certainly not beneficial for the mother or the newborn. So even though we don't have any evidence regarding the actual impact because of pandemics, we do know it is not beneficial and that there is no justification to separate a newborn from the mother. Now I'd like to take the opportunity to add something else, and that's something that we've been working for quite some time. And in the intermediate and intensive care units, not in every healthcare systems, and certainly not in every country, parents, mothers, relatives are enabled to spend time with the babies. And some relatives are considered visitors. And we know from our perspective, and we recommend that they're not considered just visitors. Both the baby and the relatives have the right and the benefit of the interaction. So beyond the pandemics is also an aspect that needs to be looked into because it was already visible prior to the pandemics. Thank you. For Dr. Nidia Cruz, Ana Manota is asking, knowing that exclusive breastfeeding is one of the kangaroo plan goals, what is the rate of exclusive breastfeeding for the preterm or low-weight babies before they leave the ICU? And thank you.
Well, thank you. Thank you very much, Patricia. We're trying to improve our exclusively breastfeeding rate, and we still have only 7%. However, the children who are in the kangaroo unit are also in exclusive breastfeeding because we don't allow formula in these programs. Everybody has exclusive breastfeeding, and they are not discharged until there's good feeding techniques and the mothers can continue with breastfeeding at home. Thank you. And this question from Tulio Moreno, I think it's for Dr. Pablo Duran. Tulio Moreno from Colombia asks, based on the excellent presentations that you have shared and the differential right focus, I have known that certain events affect mainly specific ethnic groups. What actions are proposed for the maternal perinatal care in countries with high prevalence of drepanocytosis? This because perinatal, maternal, child mortality rate for transmissible illnesses like malaria, COVID is greater in patients with drepanocytosis.
Muchas gracias y otra excelente pregunta.
Thank you. It's another great question. And clearly from PAHO, the recommendations of we have been stating them in the different interventions and presentations is providing equitable care in accordance to the needs of each child. From the club, we promote a follow-up and screening and control, keeping in mind the needs being geographical, ethnical, all the aspects that could generate inequalities in the access or quality of care. In the specific care stated in the question, the answer is that, exactly. Each country, and from PAHO, we provide support to identify, and Dr. Cruz gave a great example of care, sustainability, and follow-up of the families that use a kangaroo method through telephone contact, etc. So it's fundamental to sustain care. From PAHO, we are right now drafting some guidelines for screening of perinatal conditions that may mean risk for the baby. So the idea is that these guidelines are applied so that care and specific attention that kids with drepanocytosis or another condition would mean that they would not have the attention required. And once again, I'm only going to state the last two questions very quickly. And in the same way that Dr. Mujica, I'm going to ask him to do this, to reply, to be able to close. They're asking what specific direct communication is there in the hospital with direct neonatal mortality. And the other one that is very important is what are their recommendations to address the causes of the causes in public policy in regards to health investment with public GDP that allows eliminating inequalities and inequities in health in our region. Thank you, Patricia, and thank you for the excellent questions. I don't have determining answers about them. The first one, Paulo may know a little bit more than me. He's an expert in neonatal care. And I think that question comes from Janet Avila from Peru. I think it's very good. And I know that Peru is working precisely in this proposal of creating an observatory for the monitoring of inequalities in neonatal mortality and possibly in others. And Colombia has a broad experience in observatories, especially in two, like the one in inequalities and inequality measurements and in the health equity observatory. But they're not only dedicated to neonatal mortality, but to prioritize the indicators framework in the course of life for the monitoring of inequalities. And Mexico just paid large experience in inequality. It's called ONIS. And of course, Brazil as well, for many years. In regards to the question, it's very difficult because we know that there's a recommendation, a universal recommendation, which is getting that to have public expenditure in health to correspond no less than 6% of the GDP. But this is supposed to be to maintain the possibility of getting access, universal access and coverage in health. That's what I was going to say. One of the large issues that is recommended to improve the actions on the causes of the causes, meaning the structural issues, is related to the action on the social determinants of health. And it's complex because the causes of the causes of the causes essentially mean the distribution of power, of wealth, the distribution of prestige. So they are essentially political changes that each country needs to weigh in its historical moment. There's no specific recommendation. No or international body could do specific recommendations on financial models or these kinds of great decisions. But what is true is that we have to build social capital and systems that are progressive, that are solidary, and systems that reduce the inequality and opportunities in citizens to have health. And one aspect that is very important that has been very much mentioned, but that is also complicated, is the issue of extreme inequality of income, regardless of the rest, large and deep social stratifiers that we have in our region, starting with issues related to racism and discrimination and colonialism that still exist. There are deep causes of inequality and gender inequality that are huge. Regardless of these two, as if they were not big enough, there's an essential issue in the neoliberal economic model, the only one that exists today, and that has been very well documented by Piketty, the French economist. It's called The Capital in the 21st Century. The difference to the Marx treaty that was a philosophical economic treaty. This is in econometrics. And what he shows or demonstrates is not that capitalism or the free market model is necessarily bad. What he demonstrates is that it has a congenital defect. And the congenital defect of the neoliberal model is that it reproduces really easily extreme income inequalities. We would have to be blind not to see what is happening in the world in regards to this. So the governments would have to generate some kind of safeguard to allow controlling in these deep and extreme income inequalities. These are issues that concern each government, but they are central issues. The action on the determinants in health, the education is probably the most important one, the one that greatest human capital generates, and there shouldn't be inequalities for that. Thank you very much, Dr. Mojica. Once more, I apologize for having been over time. We thank you for the questions. This session is being recorded and we will share the presentations with you. And now I have the pleasure of giving the floor to Dr. Susana Cerrulla, the director of CLAP, and with her colleagues of the organization, we have the pleasure also additionally than doing this seminar and working jointly in this topic as a team. Thank you very much. I say goodbye and I hand the floor to Dr. Susana Cerrulla. Thank you very much, Patricia, and thank you to each one of you who is still with us. It's been a huge audience that leaves us very happy. I just want to recover a few ideas so that we can leave and take back some action points. What are we seeking to bring for each one of you that are helping us so that as decision makers and as healthcare professionals, as students, you can have as actions? The first thing is what Pablo talked about in regards to the perspective of rights when we look at what mortality, neonatal mortality means and the huge burden of illness that we can have in newborns, additional to a very important number of stillbirths. I think that having this perspective makes us understand why Pablo Duran has talked so much about alliances. Alliances are fundamental. We have to work with the communities, with the families, with the other partners, doing a support network for each one of the newborns and the pregnant women to be able to avoid such high number of stillbirths, and of course, when the woman has her baby. So two main topics I think that Paulo has brought, the topic of rights and alliances. But we cannot leave aside something that marked the seminar. We have a perinatal information system. Those who don't know it, I invite you to get to know it in our page, the information system that allows having this data. If we don't have data, we cannot do anything in these issues that are being presented by Giga. We cannot understand inequity. In regards to Paulo presented, what complements the view of inequality, Oscar Mujica presented very well that the ways of being healthy or not is very different. Only one social determinant or the meanings of this. When you see that we are in a moment doing gathering the SDGs, like Sebastian spoke in the beginning, listen, how we are going to achieve what we had already achieved. And it seems that something is very important in some countries. Some countries have, we're going back and we have to do this. And I think that Nidia has brought something that I loved and I want to highlight. And now during the pandemic, essential healthcare services and the access of care is fundamental. They have to be more important than ever. We saw what at some points the incidence and prevalence of the cases, the transmission, and services were closed. We had, for the first time in the region, a lower number of hospital births, less care during birth, which is very important. But we cannot, or we have to keep on implementing more than ever all the interventions that we know that are cost effective. That's why there's the example of the kangaroo care. That's why it's so important. So I want to thank you for your participation from Dominican Republic by Nidia Cruz, because I think it brings us the reality of how a country does efforts day to day of everything that we can analyze, discuss, and recommend. But it's you and only you in each country that are able to make this be concrete. This set that is continuous between the implementation of evidence-based care and the information that allows us to better get to know and do a more important analysis, and mainly a decision that looks outside of the health environment for the structural determinants that can understand that there is no social capital that is more important in a society that a newborn. It's our most important social capital. A newborn is the one that we have to protect more than ever. So I want to thank your presence. I think the presentations have been brilliant. We will try to answer all the questions in the chat. There are a lot of them, and they were very interesting. And I want to make special mention to Sebastian. We, both of us are happy to have two groups within the Latin American Perinatology Center of CLAP and the EIH department. This is a team that works in synergy to bring activities like this one. So everybody from the IH, Sebastian, Patricia, Oscar, everybody who works with us day to day, thank you very much. And also to Pablo from CLAP, who's an advisor in perinatal health. And he has worked behind the scenes in all of this meeting to guarantee that the transmission was well. I want to thank the interpreters, to the journalist that coordinates all of this, and everybody for their contribution. So to all of you, thank you very much.
Thank you so much.
I think that today we worked for something that's very important in the development of the countries, the life of newborns. Thank you very much. Have a great afternoon.